Thank you very much. So this is more a philosophical talk than a talk based on data, because there is not a lot of data around on radiotherapy, immunotherapy, and radiotherapy combinations. So it's really more sharing some thoughts, sharing some ideas. The first question I asked myself is, what are the possible clinical situations that we could talk about when talking about trials like that? And that is really spanning the whole field of oncology. So we can talk about metastatic patients and give systemic therapy, for example, immunotherapy, and add a local treatment, radiotherapy or hyperthermia or both, to one single lesion, for example. Then we have oligometastatic patients where we are able, for example, with SBRT to treat all macroscopic tumor, but we still know that there are micrometastases around in most patients, and we could add immunotherapy to tackle that. And the third situation that we can think about is localized disease with high potential for recurrence or metastases, and it would be about improving patient prognosis and improving cure rates. And this is my background. I'm working in hyperthermia and soft tissue sarcomas, and the problem in soft tissue sarcoma that we have is that we have like 50% in high-risk patients that develop distant metastases, and normal chemotherapy doesn't really do that much to it. So we're really looking for new therapy modalities to help with that. And so I was thinking about what trials do we have. There is a trial, I don't have results yet, but there was a trial called HyperTED in metastatic soft tissue sarcoma, and they did exactly that. They used chemotherapy and added hyperthermia to one lesion that was accessible for hyperthermia. When we talk about the oligometastatic setting, we know that there's the PEMBRO-RT trial combined with the MDACC analysis, and they used pembrolizumab plus minus RT. And all of us know the Pacific trial, which is kind of the third category of doing a curative treatment in patients with a high risk of metastatic relapse, adding immunotherapy to improve patient prognosis. And so for the last two, I can show you some results. This is the studies on the oligometastatic patients with really an additional benefit by irradiating all local tumor sites in addition to pembrolizumab. And this is the outcome of the Pacific trial, where adding immunotherapy to curative radiochemotherapy really improved patient prognosis. And so these are the settings we can think about when thinking about radiotherapy, immunotherapy, hyperthermia combinations. We have to keep in mind that there are different classes of immunotherapies, and I always like to highlight that in the talks, because when we talk about immunotherapies, everyone thinks about immune checkpoint inhibition, but that's not all that's around. We do have CAR T cells that are approved and that are in the clinical practice for lymphoma, for example. And there is a lot of other things around, bispecific antibodies, which more or less belong to the CAR T cell category of immunotherapies. We have cytokines, we have dendritic cell immunotherapies, all kinds of stuff. And so you know the immune checkpoint inhibition that really removes the brake from the immune system. And you know these CAR T cells that are genetically engineered T cells that will attack every single cell in the body that displays a specific antigen without needing the second signal that an immune cell normally needs to get activated to prevent autoimmunity. And so all this adds up to questions of how do we all put that into a clinical trial design. And so for the radiotherapy and immunotherapy part, there is literature outside that asks the question. So what are the best types of immunotherapy? How do we sequence and schedule radiotherapy, immunotherapy? It makes a huge difference. There is preclinical data outside. There is clinical data in the Pacific trial. It was the closer you get the immunotherapy to the radiochemotherapy, the more the patient profits. What about healthy tissue toxicity? When you look at Pacific, grade 2 pneumonitis was higher, grade 3 was not, but there might be an effect. What are the biomarkers? How do we select patients? Is PD-1 status, PD-L1 status really the thing to go to select patients? and how do we overcome tumor resistance? Then the next questions that came up during the last years is, what about radiation dose and fractionation? So because long time it was like, well, you give one very high radiation dose, you get the most immunogenic cell death, and it must be the best. And then the paper came out that the abscopal effect in the mouse model was better with 3 times 8 gray than with 1 times 20 gray. And the mechanism behind was unraveled, and we understood that, okay, it's not as easy as we thought. And what happens when we add hyperthermia? Do we need to adjust the radiation dose and fractionation to adding hyperthermia? And then what kind of immunotherapy? Then the radiotherapy volume. You might be aware of all the discussions about irradiating lymph nodes while treating with immunotherapy. So there seems to be a less benefit of immunotherapy when you irradiate lymph nodes, because the immune system cannot respond in the best way it could. Then again, different immunotherapies. And as I said, what happens if we add a third player into a 2-player regimen where we don't really know how to put the 2 together, and now we come with a third one? But you see that it's really fascinating, and it opens up a lot of possibilities to think about. For me, it opens up a lot of possibilities to go for translational research, to understand what happens when we add radiotherapy, hyperthermia, what happens on an immune level, and how can we learn of how to integrate the third part of it. When we look at addition of hyperthermia, there are a few review papers outside, and at the moment there are more review papers than original papers, and that's what we know from fields that are emerging. That's the normal thing and the normal way it goes. And if you look on the right panel of the 2, you see that they really summarized hyperthermia, immunotherapy, and radiation. And there is a lot of rationale that it can really go well together. So you have, by the radiation, you have the antigen release, the cancer cell death, you have DNA damage. With the hyperthermia, you have the increased blood flow, the release of heat shock proteins. And then the immunotherapy kicks in and can really go for it. And for me, one of the arguments really is that, as we heard before, that the hypoxia is lowered in the tumors with hyperthermia, and there is nothing more immunosuppressive that a tumor can have than hypoxia. So it really kills every T cell that tries to get into the tumor, and it really hinders everything that you need to immunologically kill a tumor if a tumor gets hypoxic. So that, for me, is really one of the strong rationales that hyperthermia might really help in a sense of adding radiotherapy and immunotherapy, especially, again, coming back to my clinical focus of sarcomas, because we know that a lot of sarcomas are severely hypoxic. You can even see it on the MR when you have the necrotic core inside and the viable tissue outside. There must be hypoxia in the middle. It just cannot be another way. And so it's really something that is worth investigating. There are some clinical trials ongoing on hyperthermia immune therapy combinations, and also on radiotherapy immunotherapy combinations for sure. For the radiotherapy immunotherapy, I focused on the sarcomas. And you see, for example, that there is another immune checkpoint inhibitor involved, which is LAG3 targeting. So it's already approved for melanoma. And in addition to CTLA4 and PD-1, PD-L1, it's another immune checkpoint that can be targeted. And you see that there is cellular immunotherapy combinations with hyperthermia and immune checkpoint inhibition in, for example, advanced malignant mesothelioma. So there are people thinking about these combinations in clinical trials already. What about patient selection? I'm not a strong believer on PD-L1 stratification, especially if we don't talk about immunotherapy and checkpoint inhibition alone, but on combination treatments, because as we see that hyperthermia and radiotherapy both alter the PD-L1 setup of the tumor cells. So we would need to know what happens after the treatment to say if it could work or not. One piece of work that we've done is to look at immune cell infiltration in sarcoma specimens before and after multimodal treatment with radiotherapy, chemotherapy, and hyperthermia. And we looked at 3 compartments: the biopsy sample, the resection sample, and in the resection sample after the multimodal treatment, we looked at peritumoral tissue and intratumoral tissue. And the interesting finding we had is that the pre-treatment immune cell infiltration does not tell us anything about the prognosis of the patient. But what is really prognostic is the post-treatment immune cell infiltration. And in the study of ISLs, that's similar findings. So they also saw that only the post-treatment immune cell infiltration tells us something about the prognosis of the patient, which means that the pre-treatment immune cell infiltration is not a good factor to stratify for any treatment. So the question is, what can we do with that? And so one idea could be, if you look at the lowest bars, we see that the patients in red with a high CD3 and a high CD8, they have a disease-free survival of like 80 to 90%. So they are doing really well. I don't know if they need anything more than they have gotten in our standard treatment, but the blue ones are the ones that really matter. And the question is, what type of immunotherapy and at what time point can we add so that we can get the blue ones somewhere near the level of the red ones? And these are the questions that we are talking about. So to sum up, there is a strong biological rationale for multimodal concepts. However, there is limited clinical evidence now, so it's really more conceptualizing. And the immune markers we have, it's really after the multimodal treatment with hyperthermia that they are predictive for the patient prognosis. And for me, that means we need innovative early clinical trials. And for me, it means that we need a lot of translational research to understand what's going on there. And with that, I thank you for your attention.